We're going to take a case-based approach to pediatric neck lesions. We're going to start a little bit higher at the level of the nasopharynx and nasal cavity and continue caudally towards the level of the thyroid and the infraglottic larynx. If we had Dr. Connor's amazing talk at the time we were reading some of these lesions and cases, we would not have made the mistakes that you will see today. So all of the cases that I'm going to present are pathologically proven. They're cases we missed at my home institution, and we'll talk about pearls, pitfalls, what could have helped us make the correct diagnosis, and what we should have done in terms of further imaging. All right. So this is a 14-year-old boy with nasal stuffiness and snoring. We have a lot of CT images. We see opacification in the sphenoid sinuses, extending through the choana, the nasal cavity, extending inferiorly into the nasopharynx, where we have this bulbous lesion. I want to highlight here that the pterygopalatine fossa looked symmetric from the other side. It was not widened. For our differential considerations, we came up with an inflammatory polyp, maybe an antracranial polyp that was an atypical presentation, a juvenile nasopharyngeal angiofibroma given his age and gender, rhabdomyosarcoma. It's a common theme you'll see throughout these cases that we present in the pediatric population because it is a very common neoplasm. Nasopharyngeal carcinoma, uncommon in the pediatric population, but it can happen, and nasopharyngeal lymphoma. This was actually a juvenile nasopharyngeal angiofibroma. We found out when we were called to the OR to look at a pulsatile red mass that the surgeon was looking at. We had read this out as a possible inflammatory polyp. This is an atypical presentation of something we commonly see on the pediatric service. It's atypical because there was no widening of the pterygopalatine fossa, and we were ignoring some key features. The diagnosis and the demographics are so strongly associated with JNA. We really should have gone on to MRI, really to confirm. Inflammatory polyps, this will be a little bit of a recurring theme throughout the talk. They're really quite uncommon in children, particularly young children. So this is the companion case, and nobody would mistake this as, the juvenile nasopharyngeal angiofibroma. Really quite classic features. You've got this large expansile lesion, marked widening of the pterygopalatine fossa, has these flow voids, T2 signal hyperintensity, and osseous expansion of the nasal cavity. Similar age and demographic. This was a 12-year-old male with similar symptoms of nasal congestion. And here's our other companion case. This was an inflammatory polyp, similar in appearance. It's on the right side instead of the left. We have this polypoid lesion extending into the nasopharynx here. This was a much older patient. This was actually a 46-year-old female. So we were really ignoring some obvious features of the demographics and the age, and we could have done better with this case. This is a 17-year-old boy with left-sided proptosis. We have this heterogeneously enhancing lesion in the upper aspect of the ethmoid sinuses with extension into the orbit. We have osseous erosion, osseous destruction. This came to us from an outside institution with a read of a hemangioma. We did not agree with that. We pursued MRI. And we see this mildly T2 hyperintense lesion, avid enhancement in some components, but other components do not enhance very well. Our differential, we carried over the hemangioma from the outside institution. We considered a nasal pleomorphic adenoma, uncommon, giant cell tumor, and rhabdomyosarcoma. We ultimately ended up going with a rhabdomyosarcoma, but this ended up being a cousin, which is the alveolar soft part sarcoma. Things you don't want to make the mistake and confuse this with a hemangioma is there was extensive osseous destruction. It wasn't remodeling, it was really truly destruction. It extended into the orbit and had this really heterogeneous enhancement. We did not see any evidence of flow voids in it. Moving on, this is a 3-year-old boy with congestion. We see opacification filling both maxillary sinuses. We also see some little polypoid lesions in the posterior aspect of the nasal cavity. We thought these were just inflammatory polyps and kind of let the case go, thought he had severe paranasal sinus bacterial disease, and we really kind of stopped short of what we could have done for this patient. So going back to the concept that inflammatory polyps are really unusual in the pediatric population, particularly young children, when you see them, you really have to raise your index of suspicion for something more that's going on. So cystic fibrosis or a primary ciliary dysmotility disorder. This patient ended up having cystic fibrosis. So it should not have been something that we just brushed off as an inflammatory polyp, and we should have sent our patient to pulmonology for additional screening. This is an 18-year-old girl with sinus pain. If we had seen Dr. Connor's lecture, we probably would have gotten this, but we had not at that time. We see complete opacification, the left ethmoid air cells, left maxillary sinus, hyperdense secretions in the middle. We thought, oh, this is a severe bacterial sinus infection, inspissated secretions. Could this be an underlying lesion? Allergic fungal sinusitis, and this was in fact allergic fungal sinusitis. Important things to note about this in kids. It occurs in immunocompetent patients, slightly higher predilection in males. About 65% of the cases are associated with a history of asthma. And the reason it is so important to make this diagnosis is that the management between bacterial sinusitis and the allergic fungal rhinosinusitis is really quite different. The treatment is really resection of the allergic mucin. Without resecting that, this will recur. This was a 12-year-old male with nasal stuffiness, and we see this densely mineralized calcified lesion here extending in the upper nasal cavity involving the ethmoids. There is some opacification, we thought related to obstructed sinuses. We thought this may be a fibroosseous lesion, osteosarcoma, although the matrix really was not quite right. Could this be a weird-looking rhinolith? Chondrosarcoma and esthesioneuroblastoma were on our differentials, but we ultimately thought this was a fibroosseous lesion, and we were super wrong. This was an esthesioneuroblastoma. It can occur in kids. It is uncommon, but we do see it. The pitfall for this was that we did see patency at the right olfactory recess, something that we don't commonly see in aesthesios, but it can happen. This dense calcification is also very atypical, but it has been demonstrated previously in the literature, and we did ignore a small focus of osseous erosion, here highlighted with the yellow circle. So what we should have done in this case, because it wasn't clear, is proceed to MR. Here's a companion case for some other calcified nasal cavity lesions here. The sinonasal fibrous dysplasia, smooth ground glass lesion, very typical classic appearance on CT. Chondrosarcoma in the middle. We see this classic ring and arc appearance, and then the rhinolith, which we also saw in Dr. Connor's talk. Moving on and heading more inferiorly, we have an 8-year-old boy with right submandibular swelling. We see this markedly T2 hyperintense lobulated lesion within the region of the right submandibular space. There's some faint peripheral enhancement. We thought, okay, this could be a venolymphatic malformation, plunging ranula. We did not quite see the true connection with the right floor of mouth or a plexiform neurofibroma. Patient actually ended up coming back 5 years later, and we see this transspatial, very T2, hyperintense bubbly lesions in the subcutaneous soft tissues, and this was a plexiform neurofibroma. So some companion cases. This is the diving ranula. We see this beautiful connection, right floor of mouth, very homogeneous, elevated T2 signal intensity. And then the venolymphatic malformation, we see this classic ombre shading on the T2 weighted sequences and thin peripheral enhancement. Common location is also submandibular space. I'm just going to review classic imaging findings for the capillary hemangioma and venous malformations which occur within the parotid space, and I'll show some pitfalls that we ended up running into. This was a 4-month-old girl with left-sided neck swelling. We see a homogeneous enhancing lesion here. Very T2 hyperintense, small little flow voids in the middle. This is the classic parotid infantile hemangioma. Mean age is around 4 months, higher female predilection. And the presentation classically is an enlarging parotid mass in an infant. It's not present at birth. And the imaging findings we just reviewed. This is an 18-year-old girl, so older. She's got left parotid and facial swelling, and we see this transspatial lesion here involving the parotid space as well as the masticator space, elevated T2 signal intensity, and some faint peripheral enhancement, and this is the venolymphatic malformation. So these are some common parotid lesions which mimic parotid vascular malformations. Rhabdomyosarcoma, again, something you want to consider in the pediatric population. Lymphoma, mucoepidermoid carcinoma, uncommon, but we do see it in the pediatric population. Rhabdoid tumor, important to identify this early. It's a very aggressive neoplasm. Infection and inflammatory processes are also good to have on your differential. This is a 3-year-old girl with left-sided neck swelling. We see a very heterogeneously enhancing lesion with a dominant central solid component that is relatively hypo-enhancing compared to the rest of this. This was called a hemangioma in an outside institution. This was a rhabdomyosarcoma. This is a 14-year-old male, left parotid swelling. We see this T2 heterogeneously hyperintense lesion, has some fairly homogeneous enhancement. Again, this patient is much older than our classic population, and the MRI signal is really not quite right, and this was a mucoepidermoid carcinoma. Here's an 8-month-old boy with left-sided neck swelling. We see this macrolobulated, very bubbly lesion, has some areas of very avid T2 signal intensity, heterogeneous enhancement. We don't really see flow voids in it, and this is the rhabdoid tumor. It presents as a rapidly growing neck mass. It may have hemorrhage in it. It's a highly aggressive neoplasm and usually occurs, you'll see it in the first year of life. This was an interesting case. This is a 13-year-old girl with painless left neck swelling, so she's an older child. We see this fairly homogeneous T2 hyperintense lesion, some homogeneous enhancement. The clue here that we should have paid more attention to is we see all this ipsilateral left cervical lymphadenopathy, and this was Castleman's disease, the hyaline vascular type. This is an 18-year-old girl swelling and pain in the region of the right parotid gland. This was a heterogeneous T2 hyperintense lesion. We see this sedimentation or layering level here, thick peripheral wall of enhancement. This was actually called an infected venolymphatic malformation, but it was really just a parotid abscess, so this needed to be drained immediately. So it had that layering appearance on the T2 sequence. We had no flow voids, and there was this rip-roaring peripheral wall of enhancement surrounding edema and enhancement. This is a 16-year-old girl, left mandibular swelling. We see soft tissue swelling over the left mandible with extensive areas of osseous erosion. Quite a large lesion on the sagittal plane here. We did not see evidence of resorption of the tooth roots, but we saw marked osteolysis throughout the mandible. We will come back to this finding here, which is something we missed. We focused on the large mass that was smacking us in the face on the mandible and ignored a more subtle finding. The differential we came up with was giant cell tumor, aneurysmal bone cyst, amyloblastoma, an odontogenic keratocyst, brown tumor, and odontogenic cyst. So here are the companion cases. So this is an amyloblastoma, usually seen in older patients, not so much in the pediatric population, although it does occur. Angle of the mandible is the most common location and occur anywhere along the alveolus. There is no gender predilection. Giant cell tumor, we thought this was a really big contender. Our index case looked a lot like this, a very expansile area with lucent changes, female predilection, typical age is closer to our patient, and the odontogenic keratocyst usually occurs in the body or ramus of the mandible, but can be seen in other areas of the mandible. Slight male predilection, can be unilocular or multilocular. We called this a giant cell tumor. What we had failed to look here, which was included in our field of view, was here at the level of the thyroid. We see this elongated, lower enhancing lesion here with an artery seen along the superior margin. Here it is in the axial plane, snuggled up against the posterior margin of the left lobe of the thyroid, and this was a parathyroid adenoma, making this ultimately a Brown's tumor in the mandible. So some key features: higher female predilection. They are reported in the maxilla and the mandible. And you see extensive bony resorption. It's this replacement with this fibrovascular tissue and giant cells. So on histology, the Brown tumor can be confused with giant cell lesions. What we really should have done is done a more thorough review of the electronic medical record. We did see at that time that the patient had elevated calcium. We should have taken it one step further and recommended a PTH test. In her, it was quite elevated, and that would have ultimately helped us make the diagnosis. This is a 17-year-old girl with recurrent right jaw pain. We see this markedly expansile portion of the right mandible extending to involve the angle, ramus, and it also ended up involving the body. We did not see any overlying soft tissue swelling. It was really quite a bizarre appearance. We were able to find a cone beam from 7 years earlier, and this is what she looked like, really this very patchy attenuation pattern. And if we blow up this image here, we saw this onion skinning appearance to the mandible. We felt fairly good that this was not osteosarcoma that had been smoldering for 7 years. This would have looked a lot different if that was the case. We thought about an infectious mandibular osteomyelitis. We thought about the chronic recurrent multifocal osteomyelitis known as CRMO, Langerhans, and also sclerosing osteomyelitis, which is ultimately what this was. So the key point here is this is a chronic aseptic osteomyelitis without additional joint involvement. We thought this was CRMO. We asked her caring clinicians, did she have any other sites of involvement? They said no. We said, are you sure? They said, yes, we're sure. Stop asking us that question. And this was really an entity we had not considered. This is a 5-year-old boy with dysphagia. We have an axial and sagittal CT, and we see this well-circumscribed, low-density lesion here. We thought, oh, slam dunk, whatever, this is a thyroglossal duct cyst. Other things we should have included on the differential were dermoid, venal lymphatic malformation, epidermoid, and this was a dermoid, can occur midline in this location, may not have fat or macroscopic fat or calcification associated with it, so something to keep in mind. This was an 18-year-old female who had difficulty swallowing. We were able to get an MR on her. We had some concerns about how she would manage her secretions, but she did quite well. We see this expansile, very heterogeneously enhancing lesion. It was quite large, difficult to see where it came from, but ultimately it was the posterior wall of the hypopharynx. It had some scattered areas of elevated T2 signal hyperintensity. We thought, well, could this be a fibrovascular polyp? They're known to occur in the upper esophagus, the posterior wall of the hypopharynx. Could this be a synovial sarcoma, rhabdomyosarcoma? We love considering that in pediatrics. Could this be a weird schwannoma in just like the most unfortunate location? And this was a synovial sarcoma. They do arise from the posterior hypopharyngeal wall. Important thing, the chondrosarcoma would occur a little bit lower. I'll show you some cases of that. When it's posteriorly located, it's usually coming from the cricoids and retinoids, which would be lower down. So fibrovascular polyp, this was not a good differential for us to have included in our report. It's older patients. Typically is more homogeneous in T2 signal hyperintensity. A rhabdomyoma is something we also could have considered in the differential that can occur in this location. And the chondrosarcoma, we felt the location really just wasn't quite right. That would be more inferiorly located. This is a 14-year-old female with neck swelling and pain. We see marked hypoattenuation and hypoenhancement in the left lobe of the thyroid gland. We see small foci of air. We see asymmetric soft tissue thickening involving the musculature, reticulation of the subcutaneous fat. We see a peripherally enhancing fluid collection here. So we thought, okay, this could be suppurative thyroiditis with a piriform sinus fistula, papillary thyroid cancer, a branchial cleft cyst anomaly, or a venal lymphatic malformation. We went on and did a barium swallow in this patient. What I'll just highlight here is we see this opacifying tract extending from the base of the piriform fistula, extending inferiorly towards the left lobe of the thyroid, and this should be the ultimate proof. This is the suppurative thyroiditis with the piriform sinus fistula. It's almost always on the left side. You should have extremely high level of suspicion if somebody is presenting with recurrent infectious thyroiditis. The barium swallow evaluation can be very helpful for visualizing the fistulous tract. The key move is you have them puff their cheeks out like a chipmunk, like that. They're a teenager and they'll never want to do it, but just try to make them do it, and that forces increased pressure in the barium to try to track down into the pit of the piriform sinus. It is crucial to diagnosis because the treatment is not just antibiotics. They actually have to resect that anomalous fistulous tract. This was a 2-year-old male with left-sided neck swelling on MRI. We saw this very heterogeneous lesion, very closely associated with the left lobe of the thyroid gland, central area of increased T2 signal intensity, heterogeneous enhancement here. It looked really ugly. We were really concerned. We did an ultrasound. We did not see a whole lot of vascularity. We saw some very prominent lymph nodes nearby. We were pretty concerned about this. We thought about papillary thyroid cancer. It can occur in kids. Thyroid lesions in children are very uncommon, so we have a higher index of suspicion of a neoplastic process when we see them. Did not really look like your regular run-of-the-mill thyroid cyst. Maybe this was complicated. Maybe this had been previously infected or inflamed. We thought about a parathyroid carcinoma, parathyroid adenoma, atopic thymus, and an atopic thymic cyst. This was ectopic thymus with ectopic thymic cysts within it. Here are some companion cases. This was a 15-year-old girl with a thymic cyst here. Much more self-respecting thymic cyst on MRI, very T2 bright, simple in appearance. They can be really quite large. This is a 3-year-old boy with a fourth branchial cleft anomaly, very similar to that prior case we saw, hypodensity right here, overlying soft tissue swelling. And this is a 16-year-old girl with a papillary thyroid carcinoma, so it has this frond-like enhancing projection pattern, which is why we were fairly concerned in our case that this was going to be a malignancy. So the key things here is that the descent of the thymus and thyroid are very closely related to each other. The proximity of the thyroid diverticulum to the third pharyngeal pouch, which ultimately forms the thymus, they're very, very close. So thymic remnants can occur anywhere along the thymopharyngeal duct and can manifest as a cervical thymus, a thymic cyst, a cervical thymoma. You can get an ectopic thymus, and they can be intrathyroidal in location. Thyroid nodules are uncommon in children, and when you see them, compared to the adult population, they have a higher rate of malignancy. So the differential for an intrathyroidal nodule in a child, it should include thymic remnant tissue as well as neoplastic processes, and you may ultimately need tissue sampling to definitively diagnose this. Thank you so much for your time and attention.